Hello everyone. We'll begin the 25 MCQs as we are discussing every day. The first question is, you have been asked to start parental iodine infusion for a woman at 38 weeks of gestation. So what formula would you use to calculate the required doses? Okay, I'll repeat once again. You have been asked to start parental iodine infusion for a woman at 38 weeks of gestation, and what formula would you use to calculate the required dose of iron? The options is 2.4 into target HB minus actual HB into body weight, or second option is 2.4 into target HB minus actual HB into body weight plus 500 mg. Third is 2.4 into target HB minus actual HB into body weight plus 500 microgram. And the last option is 2.4 into target HB minus actual HB into body weight plus 50 mg per kg. So basically you have to remember the formula for iron infusion in pregnancy. So what will be to the question is, how will you start parental iron infusion for a woman at 38 weeks of gestation? You have to remember the formula, and the formula here is 2.4 into target HB minus actual HB into body weight plus 500 microgram. So there is nothing, you have to remember this formula here. So what is 2.4? 2.4 is a conversion factor. Target HB is whatever you have to achieve, and actual HB and body weight plus 500 microgram. And what we give iron sucrose, generally we give. Okay, next question we have. It's also a formula based question. See, a person with normal lung at sea level, that is 760 mm Hg, is breathing 50% oxygen. So what, with a normal respiratory quotient of 0.8, what is the approximate alveolar PO2? You have to, again, formula is there. Options are 713, 159, 306 and 365. So I don't think if you don't know the formula, you won't be able to tell. It is PaO2 equals to PiO2 minus PCO2 by R plus correction factor. No need for this. Okay, next question we have. What is the most common serious complication expected to occur in patients with hernia? It's an easy question, and the options are incarceration, strangulation, fistula formation or obstruction. So what is the most common serious complications? Hello. So what is the most common serious complication expected to occur in patients with hernia? And the options are incarceration, strangulation, fistula formation and obstruction. So it's an easy question, I think anyone can answer if you want to try. Most common complication of hernia? Strangulation. Strangulation is the right answer. It's the most common serious complication of hernia. Others are also there, but most common is strangulation. Next question we have, it's a pathology question. See, match the following mark structure to the correct layers of epidermis. It's basically image question, so I cannot show you. Okay, next question. Now you can tell which is the most common and severe form of lupus nephritis. The options are minimal mesangial lupus nephritis, mesangial proliferative lupus nephritis, focal lupus nephritis or diffuse lupus nephritis. So I will repeat again. What is the most common and severe form of lupus nephritis? That is the minimal mesangial lupus, mesangial proliferative lupus, focal lupus or diffuse lupus. Anyone wants to try this? So which is the most common form of lupus? Basically there is a classification from 1 to 5, 1 to 6. Diffuse. Diffuse is the right answer. Diffuse is the most common, that is class 4. Class 4 of lupus nephritis. Class 4 is basically, it's a diffuse glomerulonephritis involving more than 50% of the glomeruli. So I will repeat once what is the classification if you want. The first is minimal mesangial lupus nephritis, that is the immune complex deposition. Second is the mesangial proliferative, that is mesangial cell proliferation. And third, it's a focal segmental glomerulonephritis involving less than 50 and diffuse is more than 50. And fifth, it is global or segmental subepithelial immune deposit. And the last, what is the advanced one, is the sclerosis of more than 90%. So the next question we have, it's again pathology. A 44-year-old woman from Assam presents to you with fever and chills, and it recurs after every 48 hours. So on examination, she was conscious, oriented and febrile. CBC, LFT, RFT were normal. Peripheral smear shows the following image. So what is the drug of choice? Okay, I will tell you what is the peripheral image here. If I tell you, you know the answer. Okay, it shows it's gametocytes. Now you can tell what is the diagnosis. It's a crescent shaped gametocytes. Okay, I will repeat the Okay, I will repeat the question. 44-year-old woman is there, fever with chills, recurring after every 48 hours, conscious, oriented, febrile, CBC, LFT, RFT normal, peripheral smear shows it's a gametocytes is present in the peripheral smear. So what is drug of choice? Quinine, artesunate and sulfadoxine, pyrimethamine, artemether and lumefantrine, chloroquine and pyrimethamine. So basically you know what is diagnosis. It's malaria. And which type of malaria, if you want to tell? I will repeat the options. It's quinine. Second is artesunate and sulfadoxine pyrimethamine. Third is artemether and lumefantrine. And fourth is chloroquine and pyrimethamine. Anyone likes to answer this? Basically, it's a case of uncomplicated falciparum malaria. So now at least. Okay, I will tell the answer. The answer here is drug of choice for uncomplicated fourth. No, it is not chloroquine and pyrimethamine. It is third one. That is artemether and lumefantrine is the drug of choice for this. So you can use chloroquine, pyrimethamine, but you have to remember what is the drug of choice. Anything else is given? No, it's not written. Okay. Next question we have. It's a big one. See, second. Next question. An elderly diabetic lady was brought to the hospital with complaints of diarrhea and abdominal pain. She had recently been treated with intravenous clindamycin for cellulitis. Now she was febrile at the time of examination and blood reports were HB is 12 gram per liter, WBC is 1800 per millimeter cube, CRP is 160 mg per ml. What is the most sensitive test to detect the causative organism? And the options are glutamate dehydrogenase immunoassay, PCR to detect toxin gene, toxigenic culture, or it's ELISA to detect toxic antigen. So first you have to tell the diagnosis. If anyone knows the diagnosis, I will repeat. It's an elderly diabetic lady with complaints of diarrhea, abdominal pain, recently been treated with intravenous clindamycin for cellulitis, and she was febrile when you were examining the patient, and HB is 12, WBC is 18,000, CRP is 160. So what is the most sensitive test to detect the causative organism? So first time the diagnosis, if anyone can tell. It's having diarrhea following antibiotic administration suggests C. diffel. Yeah, you are right. USMLE. Okay, its answer is Clostridium diffel is the causative organism. So the answer will be C, that is toxigenic culture will be the answer. So clinical is suggestive of pseudomembranous colitis due to Clostridium difficile, and toxigenic culture is the most sensitive for detection of Clostridium difficile infection. So others are also there, but you have to remember it's a toxigenic culture only, sensitive. Because ELISA and all you can do, but not here. So next question, which of the following hallucination is more common in a delirious patient? Voice conspiring about him, vision of snakes in the room, feeling insects crawl over his skin, or sensing pungent smells. It's a psychiatric question. I will repeat, which of the following hallucination is more common in a delirious patient? Voices conspiring about him, visions of snakes in the room, feeling insects crawl over his skin, or sensing pungent smell. So basically visual hallucination is more common, I only told. Okay, the answer is it's B is the answer. Vision of the snakes in the room is the most common in hallucination in delirious patient. One is not the right answer. It's a B, that is the vision of the snakes. That is visual hallucination is more common in delirium patients. So next question, we have a 54-year-old woman with post-menopausal bleeding is suspected to have an endometrial lesion. So what is the gold standard investigation to confirm a diagnosis? The options are fractional curettage, dilation and curettage, hysteroscopic biopsy, or laparoscopic biopsy. So basically the question is 54-year-old is a patient and it's a post-menopausal patient suspected to have an endometrial lesion. So what is gold standard investigation to confirm the diagnosis? So anyone first tell a diagnosis, if anyone can tell. Or leave the diagnosis. How will you go through the patient if such a case comes, if there is an endometrial lesion? Okay, the answer is C, that is the hysteroscopic biopsy you will do. For any endometrial lesion, first for gold standard will be repeat options. Options are fractional curettage, DNC, hysteroscopic biopsy, or laparoscopic biopsy. Which is the gold standard? Biopsy. Biopsy is the gold standard for any endometrial lesions. It is preferred for initial evaluation of women with bleeding suspicious for malignancy. Next question we have, 59-year-old woman comes to the OPD after noticing a swelling on her neck. On examination, painless lymphadenopathy was noted in the cervical, axillary and inguinal regions with no hepatosplenomegaly. CBC normal. Lymph node biopsy showed effacement of the nodal architecture with centrocytes and centroblasts. So which of the following immunophenotype panels will confirm this diagnosis? What is that? Third is stereo. Okay, I'll repeat the question again. See, a 59-year-old came to the OPD after third stereo. I don't know, sorry. Which is the comment? Stereo. Third is stereo. Okay, so I will repeat this question again. It's a 59-year-old came to the OPD after noticing a swelling on her neck. On examination, there is a painless lymphadenopathy which was noted in the cervical, axillary and inguinal regions with no hepatosplenomegaly. So CBC is normal. Lymph node biopsy shows effacement of nodal architecture with centrocytes and centroblasts. So which of the following immunophenotype panel will confirm the diagnosis? So the options here are CD19, CD23, CD5. Second option is CD19, CD22, CD5. Third is CD19, CD79A, CD10, TDT. Or last option CD19, CD79A, CD20, CD10, CD23, BCL2. Oh, just tell me diagnosis, no need of all that. But I only cannot remember this. What is the case scenario? 59-year-old swelling over the neck, painless lymphadenopathy, cervical, axillary, inguinal regions with no hepatosplenomegaly, CBC normal, liver lymph node biopsy shows the effacement of nodal architecture with centrocytes and centroblasts. I know it's a difficult question. Can't concentrate. Same here. Okay, the options are it's a follicular lymphoma. You are right. The condition is basically follicular lymphoma. It is it presents basically at the median age of 59 years and with no such predisposition. Patient most commonly develops painless generalized lymphadenopathy. Systemic symptoms are absent. Lymph node biopsy is usually adequate for diagnosis of follicular lymphoma. So characteristic features shown in lymph node biopsy includes whatever I told, that is centrocytes, centroblast and all that. Basically it's a case of follicular lymphoma. Next question. Administration of activated charcoal will have no effect in case of what? Options are barbiturate poisoning, lead poisoning, administration after 30 minutes of ingestion, or salicylate poisoning. I'll repeat. It's what is follicular lymphoma is the answer for that. Yeah, next question we have, administration of activated charcoal will have no effect in case of barbiturate poisoning, lead poisoning, administration after 30 minutes of ingestion, or salicylate poisoning. So anyone? Basically at markers. Actually I moved on to next question. You are still there. Okay, I will repeat later on. See, the administration of activated charcoal will have no effect in case of barbiturate, lead, administration after 30 minutes of ingestion, or salicylate poisoning. Yeah, the answer is lead poison. Lead poison, there will no effect of charcoal with heavy metals, corrosives, cyanide, hydrocarbons and alcohol. So yeah, and when do you use charcoal? Anyone? Basically it is within 1 hour you can use, but not in case of this all that heavy metals, corrosives, cyanides, hydrocarbons and alcohols. So an exception to the above rule can be made in cases of poison that slow gastric emptying or after ingestion of substance that leads to bezoar formations. Yeah. Next question we have, a diabetic patient presents with periorbital swelling as shown below. She complains of a significant visual impairment and a fungal etiology suspected. What is the most appropriate drug for this condition? So options are itraconazole, liposomal amphotericin B, ketoconazole, broad-spectrum antibiotics. From the picture only you can tell what is the case. Basically it is very, you can go. So basically here it's very common in COVID. Recently only it was there. Yeah. So yeah, I will repeat the testing. The diabetic patient is there is a periorbital swelling is there, and she complains of significant visual impairment and the fungal etiology suspected. So anyone knows what is the fungal etiology? Recently in COVID you have done what is, it's a periorbital pus will be coming out of the eyes. The similar diagnosis will be Black fungus, yeah, you are right. Black fungus, that is the invasive mucormycosis, is the right answer. But yeah, what is the drug of choice for that? Appropriate drug: itaconazole, liposomal amphotericin B, ketoconazole, brospertum, antibiotics. Anyone? What is the drug of choice for mucormycosis? Mucormycosis, yeah. What is the drug of choice? Itaconazole, no, yeah, amphotericin B is the right answer. Liposomal amphotericin B gives. We give invasive and invasive mucormycosis treatment of choice. So this was the easy question. Yeah. Then we have, which of the following is the best screening investigation for metabolic disorders? Western blotting, tandem mass spectrometry, PCR, or gel electrophoresis? So which of the following is the best screening investigation for metabolic disorders? Yeah, bye. Western blotting, tandem mass spectrometry, PCR, or gel electrophoresis? Very easy, yeah. Okay, this one also is easy, you can tell. Best screening investigation for metabolic disorders: Western blotting, tandem mass spectrometry, PCR, or gel electrophoresis? Anyone likes to answer? ABG? ABG is not the option only. Western blotting, tandem mass spectrometry, PCR, gel electrophoresis. ABG is in pediatrics, I know, but no, it's not there in the option here. Okay, the answer here is tandem mass spectrometry is a technique of choice for screening neonates for inherited metabolic disease. Electrophoresis is also not the answer. It's B. That is tandem mass spectrometry. Yeah, it's tandem mass spectrometry, a technique of choice for screening neonates for inherited metabolic disease. So the next question we have, which of the following is true about Chicago classification? So the options are: classification is based on readings obtained by classic manometry. Type 3 is a spastic achalasia. It divides achalasia into 4 types, and pre-oral endoscopic myotomy is the best treatment for type 1 achalasia. So first of all, you should know what is Chicago classification. It's for achalasia cardia. So which of the following is true? Finally, by from a long time I'm saying that. Yeah, the classification is based on readings obtained by classic manometry. Type 3 is the spastic achalasia. It divides achalasia into 4 types, and D is the per oral endoscopic myotomy is the best treatment for type 1 achalasia. So anyone? Basically, Chicago classification for achalasia cardia. Basically, see, it's, if no one wants to answer, the true here is, that is type 3 is the spastic achalasia. Basically, it's a division. You have to remember, it's from 1 to 3, and total 5 are there basically in that classification. So you have to know class 3 is spastic achalasia. If you want to tell, you have to remember all the. It's from achalasia 1 is classic, achalasia 2 is with esophageal compression, achalasia 3 is spastic, what I told, and hypercontractile esophagus, that is the nutcracker esophagus, and last is distal esophageal spasm will be there. So this classification you have to remember, there is no choice. Next we have, what is the drug of choice for inverse glaucoma? This also I think everyone knows. If not, I will tell. Options are pilocarpine, prostaglandin analogs, timolol, atropine. So what is the drug of choice for inverse glaucoma? So anyone know what is inverse glaucoma first? Because otherwise you won't be able to answer this. It's a type of pupillary blood glaucoma. Anyone wants to try? Pilocarpine, prostaglandin analogs, timolol, or atropine. Which is the drug of choice for inverse? Basically, it's a secondary angle closure glaucoma which is aggravated by mitosis and released by mediatic and cytogenic agents. Okay, I will tell the answer. The answer here is D, that is atropine is the drug of choice for inverse glaucoma. And what are the causes of inverse glaucoma? What they have given is malignant glaucoma, then anteriorly dislocated lens of Weill-Marchesani syndrome. Okay, I think you are getting it. What I am telling, it is inverse glaucoma is a type of pupillary blood glaucoma. That's it. Next we have, it's also which of the following is not a symptom of severe dehydration? First, drowsy child, skin pitch decreases slowly, thirsty child, or sunken frontal. It's an easy one. See, I will repeat. Which of the following is not a symptom of severe dehydration? Drowsy child, skin pinch retires slowly, thirsty child, and sunken frontal. Anyone please at least this, I think, aspect. Not a severe symptom of severe dehydration. Okay, I will tell the answer here. The answer here is C. Which of the following is not a symptom of severe dehydration? That is thirsty child. Because thirsty child, if it is there, it is some dehydration, not severe, not even moderate. It is simple. It is thirsty child is some dehydration. And severe, we all know that is sunken eyes, skin pin goes black slowly, drinks poorly, drowsy, lethargy, unconscious. Yeah. No, B is not the answer. B, skin pin is retired. It will be there in severe. But thirsty child won't be there in severe, it will be in some dehydration. Next we have, what is the gold standard diagnostic test for airborne contact dermatitis? And the options are radioallergo solvent assay, patch test, serum IgE assay, or serum eosinophil count. I will repeat, which is the gold standard diagnostic test for airborne contact dermatitis? And the options are radioallergo solvent assay, patch test, serum IgE assay, or serum eosinophil count. Airborne contact dermatitis. Anyone? If anyone wants to answer. Okay, the answer here is patch test. Patch test is the diagnostic test for airborne contact dermatitis. And what they have written, it is to document sensitivity of to a specific antigen, and it comprises of suspected allergens are applied to the patient's back and covered for 48 hours. After the patch is removed, the area is examined for delayed type of hypersensitivity. SEOC, no, it's not eosinophil, it's a patch test. What to do? Okay, next question we have. A case control study was conducted to evaluate the association between lifestyle risk factors and the prevalence of dyslipidemia. So, which of the following is not an advantage of this type of study? Basically, it's a PSM question. If you have read, you can tell. The options are incidence can be calculated, no risk to subjects, easy to carry out, and suitable for rare diseases. I will repeat. It's a case control study which was conducted to evaluate association between lifestyle risk factors and the prevalence of dyslipidemia. So, which of the following is not an advantage? Not an advantage of this type of study. Incidence can be calculated, no risk to subjects, easy to carry out, or suitable for rare disease. Anyone? Just try if you don't know PSM, because many of us don't like to study this subject. Anyone? Okay, the answer here is no one wants to try. The answer here is A. That is, incidence can be calculated if the basically not an advantage for case control study. Incidence can be calculated in B. No, it's not B. See, incidence can be calculated in cohort studies, not in case control studies. Yeah, it is calculated in cohort and also known as longitudinal studies. So basically, in case control you cannot calculate incidence. And others like no risk to subject, easy to carry out, suitable for rare disease, are all the points goes towards the case control study. So next question we have, which inflammatory marker is of prognostic significance in COVID-19 patients? IL-6, ECR, NLR, PCT. This everyone can tell. Which inflammatory marker is of prognostic significance in COVID-19 patients? IL-6, ESR, NLR, or PCT? This answer I want from everyone. Well, we have been given duties on COVID. IL-6, IL-6 is the right answer because it's an interleukin 6 associated with critical and fatal COVID-19, and option B, CD are also inflammatory, but prognosis is IL-6. Okay, the answer, next question. 40-year-old female is there with burns over her abdomen, both limbs and back, and presented after 8 hours. So, which of the following is the formula for calculation of fluid infusion? So, basically, you have to know the formula. If I will tell, okay, just name the formula. What is the name of the formula? What is the name of the formula for fluid resuscitation in burns? Options I won't give. Formulas are here only. That's why. Anyone? Formula for resuscitation in burns. Because here they have given the options. Partland is the right answer. But what they have given is 2 ml per kg and all that they have given. It is, because you have to learn the formula, that I cannot help. But it's the Partland formula is the right answer. Next we have invagination of which of the following structure will form the external auditory canal? First pharyngeal arch, first pharyngeal pouch, second branchial cleft, and second brachial groove. I will repeat, which of the invagination of which of the following structures will form the external auditory canal? It's the anatomy. So the options are first pharyngeal arch, first pharyngeal pouch, second Brachial left or second branchial groove. So if you know the anatomy, then only you can. Embryology, it is the embryology question. Which of these gives rise to aortic meatus? Anyone? We have to remember this question. Yeah, the answer is no, not pouch. I also thought that, but the answer here is first pharyngeal arch. It's not pouch. See, first pharyngeal pouch is it gives rise to tympanic membrane and eustachian tube, not the aortic meatus. So aortic meatus is basically first pharyngeal arch, not pouch. Next question we have: a patient is brought to the hospital with complaints of pain around the left hip joint following a RTA. On examination, the affected limb was flexed, adducted, and medially rotated with obvious shortening. So, what is the most likely diagnosis? And the options are anterior hip dislocation, posterior hip dislocation, trans-cervical fracture, or IT fracture. I think you know the answer. It's RTA and complaints of pain around the left hip. Examination, affected limb was flexed, adducted, and medially rotated with obvious shortening is death. Which of the most likely diagnosis? Anterior hip dislocation, posterior hip dislocation, trans-cervical fracture, and IT fracture. Yeah, anyone? Yeah, the right answer is that posterior hip dislocation. Because in this case, they have already told it is flexed, adducted, and medially rotated. It's a case of posterior hip dislocation. It's a commonest type of hip dislocation, accounting for 80%. So what will you do? It's let him finish the question. Yeah, okay. So yeah, the whatever I was, the treatment for this posterior hip dislocation is basically close reduction. For all orthopedic, it's mostly close reduction and internal fixation, and sometimes complicated case will have open reduction. Okay, next question we have: 65-year-old man is there, presents with easy fatigability, weight loss, anorexia. On examination, he is found to have generalized lymphadenopathy and hepatosplenomegaly. And investigation shows WBC count is 1 lakh per microliter with 80% lymphocytes, and peripheral smear is given below. So what is the most likely diagnosis? Basically on peripheral smear only you can tell. Okay, I'll just tell what is in peripheral smear. It shows lymphocytes are there and cytoplasm is scanty cytoplasm with irregular nuclei containing clump chromatin. Usually smudged cells. Now you can tell in which conditions smudged cells will be present. So options are CML, CLL, Hodgkin's lymphoma, hairy cell lymphoma. I will repeat: 65-year-old, easy fatigability, weight loss, anorexia, generalized lymphadenopathy, hepatosplenomegaly is there. Investigation WBC 1 lakh, 80% lymphocytes. No, it's not. AML is not in the options only. It's CML or CLL or Hodgkin's lymphoma or hairy cell leukemia. So smudged cell is present in which? CML, no, CML is not the answer. CLL, yeah. The clinical presentation and peripheral smear points to a CLL, it's not CML. Usually whatever I told, it's not smudged cells. Many smudged cells will be there and irregular nuclei will be there. So it will be lymphocytes and scanty cytoplasm. Yeah, basically smudged cell only you have to remember. Nothing else is there. Then question: which of the following statements best describes the Wolff-Chaikov's effect? I'll repeat: which of the following statements best describes the Wolff-Chaikov's effect? Options are: decrease in thyroid hormone release due to low dose of iodine, increase in thyroid hormone release due to high dose of iodine, decrease in thyroid hormone synthesis due to high dose of iodine, or increase in thyroid hormone synthesis due to low iodine intake. First tell me, it will be increase or decrease in thyroid, because it's very... So, anyone knows what is Wolff-Chaikov's effect? Otherwise you won't be able to tell. Other name of Wolff-Chaikov's effect? C. Yeah, C is the right answer. No, C is the right answer. It's a decrease in thyroid hormone synthesis due to high doses of iodine. It's a iodine induced hypothyroidism. So you have to remember what is Wolff-Chaikov effect. It's a iodine induced hypothyroidism. So it will be low thyroid hormone and it is high dose of iodine will be there. And one more is there. See, Jod-Besdow's phenomena. It is iodine induced hyperthyroidism. So you have to remember both. First iodine induced hypo, that is Wolff-Chaikov's, and Jod-Besdow's phenomena, iodine induced hyperthyroidism. Next is the last question. 56-year-old patient, male patient, comes to you with fever and non-productive cough for 1 month. Chest X-ray was normal. HRCT is given below. What is the diagnosis? So, what is the HRCT? I will tell you. HRCT is there is a 3 in bird sign. If you know where it is, 3 in bird sign is suggestive of which? I will repeat. 56-year-old male patient, fever, non-productive. Yeah. Say 56-year-old male patient presented with fever, non-productive cough for 1 month. Chest X-ray is normal. HRCT is given below. HRCT is 3 in bird sign, and options are endobronchial TB, alveolar proteinosis, vaginous granulomatosis, sarcoidosis. Anyone wants to try 3 in bird sign? In which condition you have to see? You will see endobronchial TB, alveolar proteinosis, vaginous granulomatosis, and sarcoidosis. Bronchitis. No, bronchitis is not the answer. Anyone? X-ray is usually normal in these patients. And CT showing 3 in bird sign with linear bronchial patterns. See, bronchitis can be the answer, but in this case, it's not given in the option. So here it is endobronchial TB, because it's a fever, non-productive cough for 1 month, and X-ray is normal. So yeah, and I will repeat what are the disorders which have 3 in bird sign. That is bronchiolitis, endobronchial TB, atypical pneumonia, bronchoalveolar carcinoma, connective tissue disorders, bronchiectasis, and cystic fibrosis. Yeah, alveolar proteinosis. So yeah, in this answer is endobronchial TB. It's not alveolar proteinosis also, it's endobronchial TB, because 3 in bird is also seen, and as well as there is a history of fever and cough is there, non-productive cough is there for 1 month. So yeah, it's I will repeat last 3 in bird sign: bronchiolitis, endobronchial TB, atypical pneumonia, bronchoalveolar carcinoma, connective tissue disorders, bronchiectasis, and cystic fibrosis. So yeah, it's completed for today. Yeah, at last. So yeah, okay. Thank you so much for joining.